Okay, so this is the first video for the advanced coding portion, Learning Your CPC. This is about the only textbook that I have found out there that has more scenario-driven exercises that incorporate your CPT with your HCPCS, with your ICD-10, that kind of help bring it all together, divide it up by organ system or areas of the CPT. You should have already watched the basic coding CPC course, Evaluation Management. So this is now going to give you a little bit, every chapter has a little bit of wordy stuff reminding you different key points about that area of the CPT. But this also will be completely based on scenarios, the chapter, and will help you pick your ICD-10s for the medical necessity for the different visits or the different procedures. So this book really helps to bring it all together. I do strongly recommend that everyone, if you're gonna sit for the CPC, you try to make it through this textbook. This really does take you from that basic learning level to a higher level that you really need in order to sit for the CPC. Now, something about this book, some of the comments, people are turned off on different books because there isn't answers and stuff in them, and I get all that. This book does come with all the odd answers back here in the back. So every odd case in the book, chapter by chapter, has the answers in it. Doesn't necessarily have a rationale, but has the answers in it. So at least half of the book, right at your fingertips, you have the answers. I will try, although I probably won't do every even case, and some chapters like the labs and stuff, that's probably going to be a fairly short chapter because it's just practicing looking at the labs. So let's get started. This is chapter 1, Evaluation and Management. Again, it does start with some wordy stuff, but it is not comprehensive wordy stuff like the 321 coded book is. This book takes the absolute key points, reminds you about them, and then you apply them in the different scenarios. So again, here are some of your basics, how you count up your review of systems. Remember, we talked about this. This book comes with helping you further understand your problem focused, expanded problem focused, detailed, comprehensive, what's a part of your, sorry, I had to take my glasses, or I gotta put my glasses on because I can't read, I'm getting old. What is a part of your different review of systems, your physical exam, that type of thing. It really does do a good job of breaking it down and gives some good explanations. Over the years, I've watched this book since about, I think the first edition I bought was 2010, and I've had it every year since. Might have been 2009, 2010 actually. They're usually a 2-year span, these books are. And I've really seen an improvement over the years in some of the guidance that Carol Buck has put in. She's really done a good job building on kind of a corner of the market that I just don't see. This is a very good book if you're gonna sit for the CPC. Okay, so again, this helps go into the medical decision making and what all of that involves. There were several questions about the audit form. Remember back from one of the first videos, this takes that audit form and helps break it down. This takes the different areas within the E&M, gives you information about them. So if you've been out of the E&M for any amount of time, this does a good job of getting you back in there, what's inpatient, what's outpatient, that kind of thing. Does give you a little bit of guidance around a few different diagnoses. And then we have our first case sitting here. And this is what the cases will look like. They'll be the yellow boxes. I will warn you, and we'll see that how this book is laid out. If it's a hospital stay, there may be A, B, C, D, E, and they're all different components of that hospital stay. So kind of as we walk through it, sometimes it's confusing because in the real world they wouldn't be separated out like that by date of service necessarily. But that's just the best way to be able to illustrate what you would do with that record and the different parts of the record. So I do want to just start kind of talking about, hopefully you have the book open in front of you. You won't get too much out of watching me unless I pull over a manual. I have my CPT sitting here. I have my ICD-10 sitting here. I have my HCPCS if I need it. And I'm just going to start. If I were studying this myself, I would start reading the scenario. Now, I will tell you, for this book, any of the italicized notations up here is usually very, very good at telling you what angle you're supposed to code from, which doctor you're coding from, that kind of thing. I will say this is inpatient hospital care. So we are not, remember, we do not code from the inpatient facility standpoint. Even though it's in a hospital, we are coding from the doctor perspective and paying him for his time as he's managing his patient in the hospital. So that's how you get that. Okay, so looks to me like this is a recurrent nausea and vomiting. Patient 17, she has type 1 diabetes. She's been in several times for ketoacidosis. If you don't know about that condition, this would be a great time when you encounter these kinds of words and diseases and problems, conditions, to look them up. That will kind of help build on your medical terminology and your understanding of the record and the conditions and the treatment. She was feeling good until last night. She had a blood sugar of 168. This morning she woke up and her blood sugar was 500, which is extremely high. Patient did take her Humalog, that is a type of insulin, and Ultralente, that's another. So she's on a sliding scale and regular insulin. She had persistent vomiting, which is a symptom of ketoacidosis. Her mother called at noon and was advised to bring her in, so now she's in the hospital. Here's the medication she takes. So Humalog and Ultralente, those are insulins. Your albuterol nebulizer, she must have asthma, if I were going to guess. And here's her medical condition. She has diabetes type 1 with a history of recurrent ketoacidosis and asthma, PRN on albuterol. Now, one of the things that we learned in ICD-10, you can have type 1 diabetes and type 2 diabetes, and then actually a hybrid of them. So this patient is a type 1 diabetes. It used to be you never coded insulin with a type 1. I happen to still not ever code insulin with a type 1 because it's inherent to the conditions. If you are a type 1 diabetic, you are on insulin. If you're a type 2 diabetic, it is not inherent to the disease. Some type 2s may be on insulin, but it is not disease dependent. So I personally do not code insulin with a type 1. Now, the newest or the latest, the 2020 ICD-10, we actually had a debate about this at work, I don't know, a few weeks ago or something, and I stood super duper firm, and it kind of is left to being okay now if you include the insulin or not. So how would you be able to code that? Or how would you know what to do? I personally wouldn't do it. it would depend on your work. Wherever you work, there would be a policy for how they're going to handle that. Okay, so social history doesn't really necessarily give us much. I guess there's some diabetes running around. Family history can and can't. It's good to get an idea of the patient. Here's your review of systems. So in order to know your level of service, you would need to count up your different components in your review of systems, right here. Then you've got your physical exam. Again, you would need to count up your different components of the physical exam. We've got a finger stick, and then we have an impression. So nausea and vomiting due to diabetic ketoacidosis. So this impression is coming from the doctor. He's telling us the patient has diabetic ketoacidosis. So your nausea and vomiting now become symptoms to the definitive diagnosis. So you would not code symptoms according to the ICD-10 guidelines. You only code symptoms when there is not a definitive diagnosis. And we do have one. We have diabetic ketoacidosis. So that's going to be the whole reason that they're here today, being admitted, is because of that diabetic ketoacidosis. So that would be an E1010. Your diabetes type 1 with history of recurrent, there's really not anything to do with that because we already have that diabetes right here. And we picked the code E1010. We picked the type 1 diabetes. And then here's your asthma. So J45909. So then let's see what they're going to do. So the patient's going to need IV fluids, low doses of insulin for rehydration. She's been sluggish in the past. There's no apparent etiology. The situation has been discussed and they're going to admit. So this is the admitting, the initial in the hospital. So now let's get our CPT. And I probably won't walk through every scenario quite as slow as what I'm doing now. I'm just trying to kind of get you used to, get you a feel of how you should attack and approach these scenarios. So remember with the initial hospital care, you have a level 1, a level 2, and a level 3. All of them are going to have pretty comprehensive history. So if you're chintzy on the history, you're probably stuck with the level 1. And if your physical exam is detailed or chintzy, lower. And if your medical decision making is a little lower, usually your level 2s and your level 3s are the fairly critical or really high level acuity patients. Also, you can kind of look at the time, 30 minutes, 50 minutes, and 70 minutes. So history. So this is, in my opinion, a very straightforward note. It does not, from a medical decision making, sometimes that's how I work, I go backwards. We have 2 diagnoses. One of them really is the only thing going on, and there isn't a huge amount of care. They're going to get an IV and get some glucose, and they're going to be rehydrated. They're saying she should be able to go home tomorrow. So if they're already thinking, once we pump her full of some fluids and get her blood sugar somewhat controlled for 8, 10, 12 hours, she should be able to go home. The patient is not critical. So from a medical decision-making standpoint, I would say this is straightforward or low complexity, which because of that alone, regardless of anything else, you see your medical decision-making, it's low complexity, moderate, and high. So because it's so straightforward, 99221 would be the CPT code that I would choose for this. And so then on the next page, the 1B, this is the same patient, and it has some good discussion here. And this is the same patient going home. Remember your discharge, you have 2 codes, 238 and 239. They're all dependent on time. So if your physician or if your documentation does not give you the time, then it's automatically to the 99238, okay? And then your diagnosis codes are dependent on what they've written. So here they have the vomiting with dehydration, and we know from over here that they had to be rehydrated. So dehydration played a role. You could, even if you had wanted to, you could have put dehydration over here on the admit. I probably would have. So we have dehydration, and they're saying secondary to the early diabetic ketoacidosis. So I personally would, I would code, I don't know. I would probably code that diabetic ketoacidosis first as the principal or the primary, then the dehydration, and then the asthma. Again, you don't have to do anything with this diabetes type 1 because it's already bundled in. When you pick that diabetic ketoacidosis code, that's going to be bundled in because it's diabetes. There's a good discussion talking about the dehydration, and so that would be that. There's great tidbits in here from the trenches, people who know how to code, have been doing it, they have some experience, and maybe some tidbits of information that they want to throw out. So it's good, to read. Sometimes it's just to keep your spirits up because learning coding is not easy. It's not an easy field. But if you have an aptitude for it, it's a lot of fun. I enjoy it. I wouldn't choose to do anything else. I quit nursing for it. Okay, case number 2. This is an emergency department. This tells you, remember I said if there's any tidbits, they italicized. So this patient is case 1-2, is the same patient as case 1-1. So this is the same patient again. See, do they even have the same name? Sally Jacobson? Yep, they do. Okay, so that kind of helps you know what to do because now you kind of have a history on this patient. So we're in the emergency department. Remember, in the emergency department, you're always new. Patient, again, has nausea, recurrent vomiting with dehydration, 17-year-old. She's had pharyngitis for the last 5 days, so that's new. In diabetics, anytime you're sick, your diabetes or your blood sugars can get out of whack. She's seen her regular internist, had throat cultures. Indicates she has nausea with some vomiting the past 3 days, not really eaten anything, which doesn't help her blood sugar control. She feels poorly and indicates she's been running to the bathroom quite frequently. She does indicate that she's taken all of her insulin shots as noted below. Again, here's the same medication. So we kind of know this patient now. Family history, again, here's your review of systems. Here's your exam, and then your impression. And I don't know what we're going to do with this patient. So dehydration secondary to number 2 with possible ketoacidosis. So we've got dehydration. Number 2 is that viral pharyngitis with gastroenteritis component. We have your diabetes type 1, and then we have our asthma. So for this one, we have to find our E&M for the emergency room first. Or at least that's what I would do. So let's get our CPT. Find our emergency room choices. Whoop. I went the wrong way. Yellow. 992. Oh my gosh. Here they are. Oh my gosh, I was probably on the page and didn't even know it. So here's my emergency department. Doesn't matter if you're new or established. So we've got to determine the history level, the exam level, and the medical decision-making level. So So in this one, the patient will be treated with IV fluids and insulin. Once she's able to eat ambulatory, she'll be able to go home. So this is not going to be an admit necessarily into the hospital. I will say, if someone is going to get IV fluids and another medication, the acuity of them is at least a 3. And that goes for your office visits too. If you're getting a systemic antibiotic, you're probably at a level 3. If you're getting a topical something, then you may just be at a level 2. But if you're getting something systemic, a med, not over the counter, then you're at least a level 3. Now that's just, I give these tidbits not in the basic stuff, but that is some of the tidbits that I give for the advanced portion. So let's look at the HPI, the history. So our history of present illness. I believe we have 6 elements. So we have location, so we know her throat and her stomach. She has the nausea, so we have that. We have the severity. She said she hadn't eaten for the past 2 days. We have the duration. It's been going on for 5 days. That's what we read. We have timing, as in she frequently, where did she say? She frequently goes to the bathroom. Modifying factors, she's been taking her insulin shots, trying to help offset the nausea and vomiting in the hopes that it was more ketoacidosis and not something gastroenterological. Associated signs and symptoms, we've got fevers, chills, cough, headache. We have a lot of stuff in here. Hasn't been eating well. So we've got 6, so I'm just going to write that down. We've got 6 for an HPI. Now let's look at the review of systems. We have 10 elements, so we have eyes, we have ears, we have we've got GI as noted above, GU as noted above, which counts, cardiac is negative, shortness of breath has no, but it's still being, so that's 6. Hematologic is negative, that's 7. Neurologic is 8. Psychiatric is 9. Sleep pattern, she's on. So what did I miss? I have 9, but I think there's 10. She's had, is there anything with her? It's noted above. No, sorry, I gotta read instead of talking so much. Oh, immunologic, infectious disease, negative. So that's 10. So now we have 10 for review of systems. And then the exam. So we have our constitutional because we have all of our vital signs. We have 2 body areas. We've got, eyes is an organ. We have neck, which is a body area. Nodes, that's your lymph nodes. We've got abdomen, that is soft. We have 6 organs, so that was body area, 6 organs. So we have eyes, tongue, or otolaryngologic, that's tongue, respiratory. Surely we have respiratory. Yeah, here's respiratory. We have cardiovascular. Oh, here's another respiratory, cleared auscultation. Cardiovascular, tachycardic is present. Tachycardia is present, probably because she's running a fever. You usually get tachycardic with a fever. Lymphatic is those lymph nodes. here. Neurologic, we should have normal reflexes. So altogether, we have a total of 7 organ systems. And I think you have to have 8 to be comprehensive. So because we have 7 organ systems, this is a level 3. So that's a detailed. Now let's look at our medical decision making. So her diabetes may or may not be within control, has to be decided. Her pharyngitis must be worsening because she's in the emergency room. It wasn't getting better at home. She has dehydration, which is a new problem. She does have the stable asthma, but it's still, although it's stable, it's still something for the physician to think about. And then what is the risk of this patient? If this patient were to walk out of the emergency room now and not seek treatment, is there high risk or not? I think there's enough risk, just like there for when we put her in the hospital here, this was her admit in the hospital. So the decision was already made from a risk perspective, what to do, and the plan was very straightforward. That's why that differs from her going into the emergency room. She's showing up not knowing how she's gonna respond to medications and that kind of thing. But as complicated as we might think this is, the doctor still says she may still be able to go home. If she's able to eat something and can walk around a little, which means her symptoms would not be flaring anymore, she might be able to go home. So it can't be a level 5. So now I'm gonna bring this back since we've kind of walked through that. We know we have a detailed exam. So here we have a detailed history, because we have 6. We have a detailed exam. We don't have comprehensive, so this one's out. We have more than what we need for these levels. So I would say 99284 is what we punch our levels into. So 99284. And then we're going to, from a diagnosing, we're going to give her the dehydration. We're going to give her the pharyngitis. We're going to give her the diabetes. We're going to give her, and that's just an E109, type 1 unspecified, because they really haven't, possible doesn't link it to anything. The asthma, J45909, and then we're gonna because they don't come out and diagnose gastroenteritis as an actual condition, they said there's a component of the gastroenteritis, and they didn't come out and tell us she was ketoacidosis. We're still gonna have to pull up that nausea and vomiting, the R11-2. Because we do not have a definitive diagnosis here telling us for sure what the nausea and vomiting are symptoms of. Could be gastroenteritis, could be ketoacidosis. We just don't know. Okay, so moving on. Again, and I'm not going to go through every one of these. I just want to kind of, just want to kind of give you guys an idea of how to work through it. If you need the answers, you just need to let me know either by email or in the comments, and I'll get you the answers. So case 3, this is another inpatient. We've already kind of done that, so I'm going to let you guys do case 3. The answers are in the book. You can always let me know if you have questions. Case 4 is another initial into the hospital. I'm not going to do this one, and I'm not because there's an excellent discussion for it. So again, when you go to tackle these scenarios, start at the top, get to know, read your italicized, get to know the patient. Get to be comfortable with the flow of the note. This case 1-4 looks awfully wordy to me. So it's, you probably here at the beginning, you're going to get hung up some. That's okay. That's okay. Has a great discussion. I think you will have no problem understanding that. Case 1-5, again, has great discussion. Just reproduce what I did walking through. You've got your progress notes. Your italicized will tell you what to do with that. Progress notes here. Again, there's a discussion. Where there's a discussion, I'm probably not going to waste time in a video. Just saying, my videos are long. I don't know how you guys listen to me that long. Oh, I wouldn't want to. This green, okay, so this is case 1-7. Has a great discussion here. This green box on page 34, if you ever do risk adjustment coding, which I'll be hopefully posting stuff for the CRC in the next few months, this understanding how to code your hypertension when there's CKD on the chart is vital. You have to know this. If you were to take a test, an assessment to get on somewhere working, I'm 99.9% sure something to do with sequencing or what to do with your hypertension code when there's CKD on the chart, that would be on it. So this would really be good for you to study and get to know, in my opinion. Again, here's progress, and then a discharge summary. These are a little bit easier. I kind of want to get to a different area than right here, a different area of the E&M. Remember your discharge summaries. There's only 2 codes, 99238 and 99239, divided by time. Okay, so now you have some wordy stuff again. So all those cases up to this point were about the wordy stuff, kind of determining your level of service. Now we're getting into a little bit different portion of the E&M with your critical care services, prolonged services, standby services. Again, this is concise, wordy stuff that very much tells you exactly how to code these things. So here is a consult. One of the things you need to know on consults is it inpatient or outpatient. This is in the outpatient clinic. 37-year-old female was asked to see by Dr. Landa. So that is critical to knowing that this is a consultation. That's how you would know. Somewhere in your documentation, it needs to tell you that a doctor asked another doctor to see this patient. And then it will culminate, you may not see the documentation of it, but in the real world, it culminates in the consulting doctor sending a report to that primary care doctor or whoever the doctor was that referred them. And that closes the loop. So this is the documentation proving to me through documentation that this is a consult. Okay, so she's got some painful varicose veins. That's probably the picture that you're seeing there. She got some when she was pregnant. It happens. She works in a nursing home. She uses support hose. She's had no pelvic radiation, which could have been maybe the root cause. She's had no previous thrombosis. She's had a hysterectomy. Current medication, she's on Premarin, so she's getting a hormone supplement. Physical exam, very limited. There's no obvious varices. The saphenous vein, so that's just of the leg. The other area of the varices, so that's all this doctor's done is look just at the legs. Very, I mean, problem focused if there ever was one. We discussed in detail indications for vein stripping. We talked about sclerotherapy, pigmentation. She wanted to have a few of the veins injected. So there's multiple different treatments that they're talking about to see maybe what would be the best for her. And the other problem is that this time we're not able to get the 3% sulfate that they need. Given the location of these veins in the upper leg, I think any injection were to be done, it would recommend using the 3% solution. So he wants to do something, but he can't because it's not on the market. We decided to give her a prescription for the different stockings. I told her to call us in 3 months. So now let's go to consultations. Okay, here's consultations. This is office or other outpatient consultations, so I'm in the right place. So here we have problem-focused history, problem-focused exam, straightforward medical decision-making. We have expanded problem-focused history, expanded problem-focused exam, and straightforward medical decision-making, detailed and comprehensive. So I've got to go back and look. These consultations are newer established, so this is a new patient, so we have to meet all 3 components. So looks to me like this history seems more than just problem focused, in my opinion. He goes into quite a bit of depth in trying to figure out if pregnancy caused it, or if she had some kind of radiation or something like that. So I'm thinking that the history is a lot more detailed, or is more expanded problem focused than it is just problem focused. Although that physical exam is fairly problem focused. So let's see how many components we come up with. So we have location, which is the thigh. We have severity. It says her pain is rather severe. Context, she developed it after pregnancy on her feet for long periods of time. She has tried support stockings, so that is modifying factors. And the timing of it is when she stands for long periods of time. So that would be 5 components of HPI. So that's expanded problem right there. Now, review of systems. We don't need much. So we don't really have a review of systems, but we kind of do built in here. So he tells us there's no previous deep vein thrombosis, so that's cardiovascular. And then he tells us she's had a hysterectomy, so that's urinary or genitourinary. So we have 2 elements of review of systems, so that's enough for expanded problem focus too. So our physical exam, we have 2 body areas, so both extremities. That's all we really need because they're looking at both legs, looked at the saphenous vein on either leg, so they've looked at each leg. So that would be problem focused. And then our medical decision making, this is a new problem for the doctor. Multiple different ideas of treatment. So that would be, in my opinion, a moderate level because there's multiple, it's not straightforward. He has multiple ideas. Just because he can't do the solution right now, I think he plans to if it comes back on the market. So I think the medical decision making is moderate, which is probably too much for our expanded problem. So here we are back at our consultations. We're stuck because we have to meet 3 out of 3 components. We have expanded problem focused history, expanded problem focused exam, straightforward medical decision making. We have to get all the way to a level 4 for a moderate complexity of the medical decision making, and we just don't have I think our medical decision-making may be a level 3 or a level 4, depending on how you look at it. But our history and our exam is not, so that's gonna keep us back. So I would code this to a 99242 in order to meet all of the components, and we just have extra medical decision-making. This had good discussion, but I did wanna wanted to kind of walk through it so you would see it. 111 is another consultation, but that your answers are in the back and it has a good discussion. 12 is another consultation. 12B is the progress note. 12C is the progress note, all the same patient. Let's look at critical care, case 113. Again, read your italicized information. This is gonna also have a good discussion in it from a diagnostic standpoint. Okay, so here we, this doctor's been asked, excuse me, for an opinion on the patient from a critical care standpoint. So this doctor's coming in strictly for critical care. Patient 62, multiple admissions, multiple acute alcohol intoxications or detoxifications. Patient's brought to the emergency room. Patient was noted intoxicated. What his blood level was. Blood was drawn. Patient was then placed on Ativan. Patient was being placed on initial mechanical ventilation, so that means he was not breathing on his own. Goes into quite a bit of discussion about or documentation specifically to the vent. Had different labs, hemogram. He has a past history of hypertension, nicotine dependence, alcohol abuse dependence, and questionable CAD. Family history, social history, medications, looks like he's only on a hypertension med. Review of systems is unobtainable at this time because he's intubated. That means it's comprehensive. If because of the patient's status, you cannot get a review of systems, then it's the full review of systems, it's comprehensive. The history here is pretty good too. I probably wouldn't even take we've got past family social history, I probably wouldn't even take my time to count that up because it's critical care anyway. Physical exam, I don't know, we can see about counting this up in a minute. I would imagine, just my guess, since we know this is critical care time, it's a comprehensive note. So here's all of the itemized what they're doing. They're putting a Foley in, they're doing an NG tube, IV, probably more than a banana bag. Reviewing blood gases, they're recommending that they try to wean him down. Hypertension, psych issues, continue to follow this patient from a critical care standpoint. Dr. Green's going to take over in the morning, and then here is key to critical care. I spent a total of 90 minutes evaluating and reviewing the patient's medical record. I spent another 10 minutes discussing the case with Dr. Green. So we have 100 minutes of critical care. So that's what we need to plug in. So when you get to critical care, that make it easy on yourself and just plug in, use this table, plug in your time. We have 100 minutes, that falls between 75 and 104. So that's a 99291 and 99292. Boom, done. You don't have to think about it anymore. So from a diagnosing standpoint, we haven't talked a heck of a lot about the diagnosing. So from a diagnosing standpoint on this one, it's a little bit more complicated. So I wanna kind of talk through it. So what do we know about this patient? So number one, this patient is in for alcohol intoxication. The toxicity is dose related, but tolerance has a wide variation. Anytime you see this is going to be in the drug table: alcohol, beverage, poisoning, accidental. They did not intend to have alcohol poisoning, but he's no longer able to breathe on his own. So he clearly is intoxicated to the point that he has alcohol poisoning. So that would be a T510X1A, A for the 7th digit because this is the first, the initial visit. The second would be probably the next. So he has alcohol poisoning, which has affected his breathing. And what was going on with his breathing was tachypnea, really fast breathing. And I'm trying to find where that was. I coded these before, so I should have underlined my stuff. It was placed, intermittent dosing, we've agreed to anesthesia, the patient was placed. So the patient had decided to contact me and we've agreed to have the anesthesia service intubate the patient. But where does it tell us he had fast respirations? Because in the physical exam, he has 16. But he's got tachypnea somewhere. Oh, respiratory depression right here. Okay? With levels excess of 400 respiratory depression. So that's it. There's your tachypnea. Which is F or R0682. And then you've got your alcohol intoxication acute, clearly, which is F10229. You also have your hypertension, which is your I10. And then you've got your Z9911 for dependence on the ventilator. Now, he just came on the ventilator during this stay, so I question whether you would, I don't know. Anyway, so yeah, yes, code the ventilator dependence because he's on and he's dependent, although they are trying to wean him off already. They do say he has questionable COPD. You cannot code that. You could code the tobacco use, the nicotine dependence if you wanted to. That would very much depend on the rules at your, wherever you work, whether they're going to include that or not. Here's good discussion about it. There's some wordy stuff about disease processes. I would very much read them if I were you. ICU report, this is again going to be some critical care. So I'm going to let you code that one. Just take pretty much your critical care actually is pretty easy because you can read it all, but the doc has to give you his time. And here he gives it to you, 60 minutes. So that's how you come up with your CPT code. And then your reason, this left frontal lobe hemorrhage, that's the whole reason for it. So that's the stroke. So all you have to do is find that specific ICD-10, which is I-61-1. Okay, another critical care, you do have the answers to that one. Good discussion, very good discussion. Another critical care, 16A. It has several components, 16A, B, C, and D, or A, B, and C. Another good discussion. Again, these discussions every year, year over year, Carol Buck adds to it. And I really do think if you follow the discussion, if you read the scenario and then follow the discussion and go back and reference the scenario, it will really, really be helpful for you. 17 is another critical care. 18 is just an office visit. And aren't we thrilled just to see an office visit? If I were coding all of these, I'd be thrilled to see this. So we know it's at the clinic, who the doctor is. The complaint is dizziness. They're established patients, so that tells you whether you're going to go with a new patient or established. 32-year-old feeling well yesterday, developed some dizziness, which has been persistent. She feels like she has something stuck in her throat. She's concerned she may have a thyroid problem. She has a history of hypothyroid. Then they talk about the meds she takes and the blood work. Objective, white female, appears in good health, has all of her vital signs, which that's one organ system. Neck is supple, so that's a body area. No palpable thyromegaly, so that's checking out the thyroid. So his assessment is hypothyroid for her. Her dizziness is because of her hypothyroid, and he's going to increase the synthroid. So again, remember what I said? This is extremely straightforward note, but although the patient has been taking synthroid, she's now going to be taking a higher dose. That is a prescribed medicine. There is the unknown as to how she's going to react to it. So that's like taking a new med because that dosage will be new to her. So pretty much that's going to be a level 3 anywhere you look. So the medical decision making, because they've pulled blood work, gonna pull blood work in 3 months and change the dosage, that would be fairly, it's not low risk. So let's look at these. So here you have, it's gonna, although the risk is only a component of medical decision making. So because it's fairly straightforward, it is a new medication, new dosage of the medication, but the medication is not new. It can't be straightforward. Straightforward maybe would be keep taking the meds that you're taking, come back in 3 months. Low complexity is, okay, you're doing pretty good on the med that you're on, but let's up the dose and see how you do. So there's a little bit of an unknown. Moderate complexity would be, I don't think your dizziness is caused from the hypothyroid, so let's get you in for an MRI or a CAT scan. We need to look at your carotids. We need to look at get an MRI of your brain, something like that. Now we're looking at multiple different diagnoses, not just one, and looking at multiple different things that could be wrong. So I think this is we only had to meet 2 out of the 3 criteria because she's established anyway. I think it's not straightforward, but it's low complexity, but it has enough risk to it that it isn't straightforward. And then we've got our problem focused and history and history and physical exam. So I would go with 99213 and then E039 for the hypothyroid. That one actually was a pretty easy one. Here's another office visit. I'll let you do that. That'll be pretty straightforward. Make sure you know whether they're a new patient or an established patient. 19 has several components to it. Now we have a little bit of wordy stuff. Now we're going to do some codes. Do some codes from the observation area of the E&M. So here we have patient in the observation unit for acute diarrhea and volume depletion. She's 52 years old, who's known to have chronic renal failure, presumed to be related to her lupus nephritis. She was vacationing, hasn't felt well, having diarrhea. Diarrhea is mostly loose, gives lots of detail about the diarrhea. She did see a doctor in Jamaica. She's been frustrated with her care. Here's all of her medical history, which is fairly comprehensive. All of the medications that she's on, believe it or not, that's what a lot of folks are on, sadly. Or not sadly, may make them feel better. Here's your review of systems. Here's your physical exam. The different labs that are being done, checking on her. Remember, she's in observation. And then the reason she's in observation is for the diarrhea. They don't know about her renal function. She has metabolic acidosis secondary to the diarrhea because she's just losing too much. Her body can't keep up. She has chronic renal failure related to her lupus nephritis. The plan is to admit for observation. They're going to do a D5W IV with some bicarbonate. Repeat the labs in the morning. She needs an ultrasound, so they're really fairly comprehensive here in what they're doing. Had a long discussion with the patient, spent 60 minutes out of 85 with the husband. Also discussed her acute problem. We've discussed the possibilities of secondary causes of the hypertension. We do not even have a tissue diagnosis on her renal failure. I will probably discharge the patient tomorrow if she's feeling better and her diarrhea is resolved. Now remember, this is observation, and you can be in observation. It's generally 24 hours, but more than that. So because they didn't discharge her the same day, remember we have two different parts to observation. One is observation, 2, 1, okay. One is initial going in, and then you have your discharge, and then the second, third, fourth days are your subsequent days. And then we have the area that you are put in and taken out all in the same day. You're admitted and discharged all in the same day. Okay? So, and then here's your observation discharge. So we've got to determine if she's a 99218, 19, or 20. So here, the history could be detailed or comprehensive. Physical exam, detailed or comprehensive. Medical decision-making would be straightforward, low complexity, moderate, or high. So the doctor did give us time. Remember, he spent, 60 minutes of the 85 minutes, blah, blah, blah. So let's see, in order to get that, we'd have to have a comprehensive history and a comprehensive exam. So let's see what our components are. Let me get back so we can look at the history part. So history, we have pretty good history of her vacation, seeing the other doctor. We've got duration, we have quality, it's loose and explosive, sadly, 4 times an hour, duration since last night. We have associated symptoms of the cramping, context, that renal failure plays a big role because I don't think the doc knows too much about it. I think in the review of systems, we should have 10 elements. So we've got the general, we've got EENT. So that's our general, our eyes, our nose, eyes. We've got neurologic. We've got respiratory. Sorry, I gotta go through here. Leg edema and cardiovascular. That kind of goes together. GI, 6. GU, Skin is 8. Endocrine is 9. Thyroid goes in that. So I missed one again. How do I miss that? You guys are probably yelling it at me at home. Let's see, which one did I? So we've got general eyes, cardiovascular, respiratory, GI, GU, skin, neurologic, endocrine. So that's going to get us to, okay, so that's going to get us to a level 4. So we've got a level 4 for our HPI, a level 4 in the review system. So combined, that's a level 4. Now let's do the physical exam. Let's see how much we have. I think we have 7 organ systems. So we have, do we have vital signs anywhere? Yeah, here's some respirations. Respiratory, doesn't have to be the whole vitals, just some. There's the blood pressure. Okay, so we have that. We've got general, how she looks. So that's 1. We have otolaryngologic. Don't we have? Yeah. So there's 2. Lungs is 3. Abdomen is a body area. I can't hear any bruies. Cardiac exam, so that's 4. Without murmurs. 5 is neurologic. Cranial nerves, motor power is 6. That's musculoskeletal. So we have 6 plus the general. So we have 7 organ systems. So that we have to get to 8. In order to be comprehensive. So this is just detailed. So I bet you we can probably find our, because we've got a detailed examination, we're stuck with 99218. See, I didn't even have to go into medical decision making because our history and exams require comprehensive at these levels, and I know all we have on the exam is detailed. So that's one little way to cut corners. So the level would be 99218. This does go into great discussion about the different diagnosis codes used, and it does reiterate using that different hypertension code with your CKD. Okay, so now into the neonatal. Hold on. I hope that's still recording because I just messed that up. Okay, neonatal, your newborn services, these are fairly straightforward. I did want to point out that this case 121, you have the answers for it, but here are the dates. This is January 1st, 2nd, 3rd, 4th, and 5th. And so that's why there's so many codes on here. So like, make sure you pull up that circumcision. Okay, I-22, hospital services. This is again for the neonate. This is still for the baby. Premature infant. So you're going to be pulling from, let me get my CPT back here. You're going to be pulling from these newborn services. It just kind of, the whole chapter just kind of walks its way through the E&M. 99462. So here's your newborn care services. In your delivery room, if they're at the birthing center, attendance at delivery, that's the different codes that they're looking for here. Remember your neonatal ICU codes. I'm going to reiterate this because that's what this section is. Remember these guidelines. there's a lot of procedures bundled into these codes. So really make sure that you're not unbundling and pulling stuff out. So any services performed that are not included in this listing can be reported separately. So really be aware of that. I know I told you in basic, but I'm telling you again, because this I-122C has to do with it. You're gonna pick your code from there. So all the different procedures that you see being done, check them against that list. Here's your discussion for that. This would be the same patient. This is your C and D. Again, has really good diagnosing discussions. Your preventive services, good information about your Z codes with your ICD-10s. Really good, concise information. Kind of helps. Z codes are kind of hard to get your mind around, just like the injury codes are, and the activity and what you were doing when you got injured. Those codes, they're tough to get your head around sometimes. So this kind of helps in different lingo from the 321 coded book sum up about it. This patient, when you're using these preventive services, this patient's coming in for a PAP and a physical, they're not sick. This is their annual visit. So that's the key to make you go to preventive. Okay, same kind of thing. These are some preventive, yeah. And then at the end of every chapter, you have these auditing reviews. They have the answers sitting here. Even though we're not necessarily auditing, I mean, we're just learning coding, these are really good to read through. See if you come up with the same answer or not. Well, you're having to determine if these are the correct answers or not. These answers, the odd ones, are in there too. But it does give you a little bit different angle of reading these and getting through them, and seeing them from a different angle. I think it would be good. At least do the odd ones, and then you can check your answers. Okay, and that is it for emergency, for E&M, evaluation and management. We'll do medicine next in the next video. And give me a comment if you have, or ask me a question if you have any comments or need any help. Just let me know if you need the answers to the even ones. So we'll do medicine next in the advanced coding.